Good evening, everyone. It's Dr. Tofi. Welcome to HerniaTalk Live. We're here every week as our session restarts again this Tuesday. We call it HerniaTalk Tuesdays. My name is Dr. Shirin Tofi. I am your hernia and laparoscopic surgery specialist. You are joining me, some of you, as a Facebook Live and others on Zoom, but you can also follow me on my other social media accounts at HerniaDoc on Twitter and Instagram, and most importantly, related to this episode and all prior episodes, you can watch all of them on my YouTube channel at HerniaDoc. So I've been wanting to have this amazing guest for many years. We're both very busy. She's busier than I am for sure, especially if you can follow her on social media, Dr. Sallie Sarrel. She is a doctorate in physical therapy. You can follow her on Instagram at Dr. Sallie PT, and she's very well known for the Endometriosis Summit. So hi, Sallie.
Hi, how are you?
I'm excellent, and thank you so much for making time for this. I'm so happy to finally speak with you one-on-one about all of these things. We share a lot of common likes.
It's exciting to be here. I'm usually a viewer, so to be on the other side of the Zoom is very exciting for me.
Same here. I'm a viewer of everything you post. You have some of the most, I would say, you have a great combination of information plus entertainment. It's so high energy. I want to listen to what you're saying, but I 100% agree with everything you say. So that's a great combination.
Well, nobody agrees 100%, but yes, we try to make my goal as part of the Endometriosis Summit is to make education accessible to all, because, it shouldn't just be the doctors with all the knowledge. A patient should be able to arm themselves with what they need to know.
Absolutely. So we have a bunch of questions that have already been submitted. I'd love to be able to get through some of those. Before we begin, perhaps educate my audience. So my audience mostly are people with hernias or concern that they may have hernias or hernia-related complications. But that includes people that have been referred to physical therapists. They've been told they need pelvic floor physical therapy. They've been told maybe it's not a hernia and it's something else, gynecologic or urologic, orthopedic. There's a lot of overlap in what we do. So maybe you can first explain physical therapy and then specifically pelvic floor physical therapy. If someone gets sent to that, what does that mean?
Physical therapy, especially when you're dealing with pelvic physical therapy, is a discipline, a subspecialty within a musculoskeletal education. So we deal with all things, all physical therapists deal with bones, muscles, ligaments, and fascia in a non-surgical way, but the pelvic physical therapists like to work in anything between really the belly button and the knees. And so I thought I'd take a minute. I'm not even sure you know the story or how I came to be the hernia whisperer, as our friends in New York like to call me.
I love it.
I have endometriosis, and of course, my endometriosis, like many with the disease, took 23 years to diagnose, even though my entire family's in medicine and I'm a pelvic PT. It is very hard to diagnose. And the majority of my disease was on the pelvic sidewall. So especially on the left side. Okay. And after I had excision, I had a good excision. They were removing calcified endometriosis. They were operating in all sorts of places. I come back within 4 weeks of the excision and I felt great. You could see the inflammatory effects of the disease were gone, but I kept pointing to one spot. I have a puppy and she has a toy. So I kept pointing to one spot. I kept that spot that's your belly button between and right near the groin crease. And I kept saying my ovary hurts. They kept doing ultrasounds. They kept doing MRIs. They did, try this, try that. And no one said to me, the ilioinguinal nerve is right there. We should look at what that, right. And I am a competitive tennis player. And so the answer always was, that's why you have groin pain. And I had horrendous pelvic floor spasms, but really in one place. And I kept saying I had vaginal burning, but I didn't know at that time, like if you really break down the nerve, which we can talk about, if your burning's in one spot versus another spot, it's two different nerves.
Yes.
So I end up doubled over on the court, tennis. And then I end up having big major surgery. I have a urologist there because I have this like insane urgency, which I think comes with hernia as well.
We'll discuss that.
And I have a bowel surgeon because I have all this like rib tip pain. And I wake up from the surgery, and without my consent, they removed my ovary. They said, this is one of the most, at the time, well-known endometriosis surgeons in the world. We didn't really see anything. I also had umbilical pain. That's different. That's a different line. And we didn't see anything. We took out your ovary. You're all fine now. Now, in addition to that causing me big time problems because I couldn't get any eggs out, I went into ovarian failure. It didn't stop the pain. The pain's getting worse.
It was in the area of your pain, but it wasn't the cause of your pain.
Right. And so it took then I met a physiatrist, and they were like, did you ever hear about these, you don't really need a bulge for hernia? Well, it took 3 years for me to find someone who believed me, and I'm learning how to do all these techniques as a pelvic PT. And then it took, after I found the person, it took me 9 months to get him to operate. And I had bilateral inguinal and femoral and an obturator, which the pelvic, right. So
that's a lot. And you were a pelvic floor PT already by that time?
Yeah. Not only pelvic floor PT, but I was already traveling the world talking about pelvic floor PT and endometriosis and presenting research all over the world. So then I switched, and I do a lot of work with this hernia. And the first year I was working as a pelvic PT in endometriosis, I really only saw endometriosis patients at that time. I found, out of 36 patients, I found 22 hernias. So
based on your exam or their story?
I would do an exam.
Okay.
At that time, I could gather the masses. I would do an exam. I then had a different physiatrist who would do a block if she needed to. And then I would have them confirmed by a general surgeon who specializes in this.
Wow. Now,
what I'm always amazed by is the people who come in, and my Instagram is filled with that. No, I have cysts. It's really not the cyst.
Yeah.
Because the cyst itself, endometrioma causes pain, but a simple cyst isn't causing the pain. It's the inflammatory response around the nerve.
Yeah.
And then I also see, I got it over the weekend. Someone got a hold of my cell phone and they were texting me symptoms. This happens all too often. And they're like, it's Pudendal. It's not Pudendal.
Oh my God, you're hitting on all the topics we're going to be discussing.
And she's like, my PT says it's Pudendal. And I'm like, your PT took out a grease pencil and marked the nerve, every ounce of the nerve, and then found that that's Pudendal, or was it really a different nerve? Yeah. So this was my story. I also had a massive ventral hernia, but different because I had a mother who was a stroke survivor, and so that led a little bit of a passion. There's obviously a connective tissue.
Yeah, I was going to say, have you been tested for connective tissue problem? So, are you double jointed?
I'm not. So before I went through the first hernia surgery, I went to someone, and in those days, they used to categorize connective tissue disorder. Yeah. Mm-hmm. And he was like, you have something, but it does, it's not exactly EDS, it's not this, but now we don't categorize
syndrome. Yeah.
Right. And then once I got older, you can really see I have a lot of mast cell responses. So when you put the mast cell together with all the hernias, there's definitely something on the connective tissue.
Mhm.
That's a great, I have a great speaker for you if you want to talk about EDS. She was amazing.
Yes, share, love it.
Yeah, I'll
Um,
email you.
Well, okay, so as you're talking about how your left ovary was kind of considered the reason for your pain, someone actually asked a question live. It says, my left ovary hurts now. It's always my ovaries. And now I'm thinking maybe it's a hernia. I feel an elastic band, heavy pulling, weighing down my pelvic area.
Well,
Yeah,
I think, I mean, you're the surgeon,
yeah,
but I think when someone says elastic band,
yeah.
so I've had endometrioma. I've had a 7 before that ovary left. I had a 7 centimeter endometrioma, so I could feel the
Oh,
difference.
wow. Mm-hmm.
And that endometrioma feels like a bomb in one spot. When people say elastic band, that makes
Yeah.
you think of a ligament. That makes you think of a nerve, doesn't it?
Yes, for sure. Pulling, any pulling since, so I think the history is really important. The area of pain is also obviously important in physical exam, but I often walk in a room already kind of knowing what's going on based on the story. In fact, my nurse Bell, who's great, like all she does is hernias. She comes to me because she does the intake first. And based on what they're saying, she's like, oh, this is not a hernia. Oh, this is a hernia. Oh, this is a hip, because the story makes all the sense. So unlike ovarian stuff, right? The musculoskeletal, like hernia stuff, activity related, burning, pinching, pulling, sometimes tearing, radiating pain, those are all kind of hernia related. But because we're women and people point down there like, oh, it must be your ovary or maybe it's endometriosis. Don't you
Well,
think
and
that's
maybe it
happening?
is. I always say to people, maybe it is endometriosis, but the thing is, you can have both. I know we have lots of men watching tonight, so I've had a lot of experience with male hernia as well. But
Uh-huh.
I'll also say, like, just because it hurts at ovulation doesn't mean it's ovarian, because
Right.
ovulation is a inflammatory experience, and if the nerve that's sitting next to the ovary is getting irritated because it already has a little compression somewhere in there, you're gonna get a response. And
Yeah.
I also think, like, one of the issues in endometriosis is nobody's ever believed. And so they go back to the doc. That was really my issue. I kept going back to the doctor that believed me and back to the doctor that believed me. But he really, it wasn't in his, it's not in his wheelhouse. I mean, hernia should be on the radar by now. We've done a lot of work, you and me, but it's not in the wheelhouse. And I think that when somebody has that burning groin pain, or they have pubic bone pain, or they have, like, patients, when you talk about the story, you have recurrent ingrowns. I had a patient who came to me, like, they would all come in, excuse me, I didn't get my laser this week. Like,
Yeah,
why?
it's too painful.
You need to ask, why are you getting the laser? Are you getting, oh, I'm getting so many ingrowns. Where are you getting these ingrowns? Can you point to that? Where is the nerve? That all of that gives information to the picture, I think.
Yeah, I think some patients don't want to give too many details. They think they're going to overwhelm you. I'm like, no, I need to know, because those little, like, for example, they can't wear certain underwear, or
No underwear. The no underwear club.
Yeah, or women wear skirts. They prefer to wear skirts, or they wear like loose pants. Yoga pants are like, it's too constrictive for them. Belts, men can't wear belts, So that little bit of detail, very helpful.
Yeah, and I think, like, there's a lot of information about, oh, it's always your labrum. It's always your labrum. It's not always your labrum.
Yeah.
And the other thing, which I learned from HerniaTalk, is really the role of femoral hernia in assigned female at birth related pain and in female hernia. And so that, like, when somebody keeps taking their hand and rubbing it down their thigh,
Front of their thigh.
right, is that the femoral hernia? And it's interesting, my father has terrible stenosis, and while I was learning the mapping, I'm mapping out his pain, and it's not consistent with where the narrowing is. And and he had hernia surgery 2 weeks later.
Oh boy.
But it helped that pain. So this pain that he always assumed was from the stenosis down the front of his thigh, really was hernia related.
And it runs in families. So your father,
Well,
genetically.
it's worse because my uncle, the three of us could stand in a row, and it definitely runs in families. Yeah. But
so this lady who she is viewing us right now talks about the ovary pain and maybe this elastic band. She also says every step I heard takes. What does that mean to you when walking or stepping?
well, I do think about the femoral hernia when people have that sort of like pain down the front of the legs when they're walking. The person that got in touch with me over the weekend, the text was, my groin is on fire from running. What I think is when you're putting compression into the system and you already have maybe a fat pad laying on the nerve, you're making a tight system tighter.
Yeah. And don't you think that also brings into hip problems? When
Yeah.
people have walking, limping issues, then it also brings in hip potential disorders into the differential.
Yeah, I think that that's the fun part as a clinician. I know that's terrible to the patient, but is it hip? Is it this? Is it that? You know, is there a little joint disorder? Is it the hernia? Can we block the nerve? Is it the adductor insertion with the pelvic floor? Is it, that's, and usually I find it's not just one thing.
Okay, so let's say I send a patient for pelvic floor therapy. What should they expect to do? Do they all get internal examinations, or?
No,
I know some people that don't get internal examinations.
I do a lot of trauma informed care, and I have to meet the patient where they are. And if you're not ready for internal work, we don't do internal work. And I also do, first of all, it's not usually you that's sending it to me. It's usually like, say, the primary care. I get a lot of physiatry recommendations, or GYN who goes, I don't know what to do. Right.
Yeah.
And
neurologist sometimes. Yeah.
Right. And maybe it's musculoskeletal. So, if I see that the person comes in, they're pointing to one or another spot, and they're complaining about burning, I'm going to do a really good interview. Like you said, where is your, and they're going to learn, like, from the start, while it's trauma informed care, I do need to know, is it the labia or the scrotum that's burning? Versus, is it somewhere else? Is it I really, that provides me a lot of information. And then I really do take out a grease pencil before I do internal work. And I try to see, I mark on the person. I don't do the fancy way the international hernia people do.
I don't either. Yeah.
Which is like, but I really, I do the X's, and I think that provides a way for a patient to be looking, like, because you can stand up, you can look at a mirror. I should have pulled those pictures. I took at white athletic tape.
Okay.
Before my big surgery, where they removed the ovary, and I marked my whole body, right? And I took photographs of it, and I sent it off to the doctor. I sent it to the urologist, and I arrived there, and I said, before we're going to go in the OR, I want you to see, this is the pain pattern. If you or I looked at that, you'd be like, we're not going to do a GYN surgery. We would, but they didn't know.
Musculoskeletal. Yeah.
Right. They didn't know what they didn't know. Yeah. And so looking back, I'm like, I should have hit them in the head, but we didn't do nerves those days. So what I do, and I think when a patient sees it, then maybe that's the moment for them. Then I definitely test out all planes of motion on the hip before I do any internal work. And then if it's warranted, I'm going to do a gentle pelvic exam. And remember, I'm not looking at, ovaries and prostates, and I'm looking at the musculoskeletal complex.
Okay.
And then,
so one of the things that we learn in patients that have hernias, so the typical hernia is like a bulge, right? That's like common. If you see a bulge, most people understand that's a hernia, but it's everything else that they don't understand necessarily is due to hernia. So pelvic floor spasm is a poorly understood problem that we see with hernias. And that could include pelvic floor pain, pain with sexual intercourse and penetration, rectal pain, urinary frequency, all of these things. Do you notice pelvic floor tenseness on the side of hernias? And then
Absolutely.
had you been able to then examine them after hernia repair and say, oh, that's much better?
Yeah, because I used to, when we were like, I used to do before and afters. And so after COVID, I treat very differently because of my life changed. But I find that you're going to get spasm in the pelvic floor, particularly in the, not in your superficial pelvic floor muscles. We
Okay.
must use it. Okay. So not
We
in your,
have, for those
not
of
in
you
your,
on YouTube, we have
right. Not in your
a lot of muscles.
yeah, not in your superficial pelvic floor muscles, but in the deeper layer of the pelvic floor,
Okay.
typically one-sided. And I
Yes.
would say like, I would almost always say halfway back, right? You're not
Okay.
talking about deep, right? And when people have that pelvic floor in one spot, right? It's like a cluster area that you can feel in your fingers. It's often triggered by hernia, but I have to say all the hernia that I've worked with, maybe one had a bulge.
Mm.
I really don't see bulge hernia, right? The men,
Yeah.
sometimes I can find that in men. But actually the primary symptom, I hope YouTube loves us tonight. The primary symptom that men is pain with ejaculation when they end up coming to me and we find
Yes.
yeah.
Yeah. Yeah. Yeah. And then how painful is the examination for the patient?
In general, if your pelvic floor, if I have to go banging around in there and you need like you need to take the rest of the day off from work, that's not working.
Mhm.
Because all it's doing is upregulating your central nervous system. So it should be, well, I hate the dentist, but it should be equal to or less painful than the dent. I have a lot of dental fear than the dentist. And I think also I do exams in multiple positions.
Okay. So
Because
this is like a digital exam. For men, it's a rectal exam, right?
for men, it's a rectal exam. I do primarily see women, and
Vaginal and rectal, or a vaginal only
I
exam?
tend not to do a rectal exam on women.
Okay.
On men, to tell you the truth, if you map it and you take a good history, I send them off to the surgeon because it's much easier to spot that on an MRI
Sure.
in a man. And if they can find help, like I can never fix a hernia. I can't fix a hernia.
Yeah.
And the surgeons can. And sometimes that's what people need. Now, after surgery, I think that people still need the muscles balanced.
Okay.
And the other thing is, if you've been in pain, some people that we're seeing have had this pain. You get horrible bloating from hernias.
Yeah. Nausea, bloating, for sure.
You need to know how to reactivate your transverse abdominals and balance your core and train your obliques to provide you the support you need so that I'm not seeing you in a year for hip problems.
I've noticed athletes who have hernias, they really feel off balance. It could be the smallest hernia and they're like, I can't engage my core. And they have like a little itsy bitsy hernia.
Well, we should talk about Rafa one day offline. I think I think there's a lot going on there with Rafael Nadal. We have not been divulged.
Well, I'd like to examine Rafael.
I'd like to examine.
I want to examine LeBron James too. Can I add that to the list?
Well, what's interesting is Rafael Nadal's thing, he says started with a psoas strain. And I see a lot of, even though
he had a rectus tear.
Well, before that, first he had the psoas, then he had a rectus tear. Now he has groin pain. I mean, we could talk about Pubalgia on him, but no one else will. So whatever. But I think I see a lot of people who come into me even though we don't typically think of the hip flexor as being in spasm, but
Okay.
they say my hip flexors are so tight, they're so tight, they're so tight. And I do see that with hernia as well, because it's
Yeah.
reacting to
Yeah,
the
it's
system.
all reacting. Yeah.
Yeah.
Okay, one comment. My audience wants to clone you, by the way. It says, can we clone you, Dr. Sallie?
Oh,
Another question. How can a male recognize if he has pelvic floor spasm? You mentioned the pain with ejaculation, but
right. I think also constipation and
yeah,
defecation related issues.
yeah,
I also think to some extent, pain sitting. And I always ask when I'm
yeah,
treating men, what is like, especially with the Peloton since COVID, where are you sitting and how often are you sitting? Because that's a good way to talk about pelvic floor spasms.
yeah,
But let's not forget pelvic floor in its own way is adductor, right? Because the adductor inserts
all related.
yeah, and also back pain and urinary. Listen, with a hernia, it's not I had a patient come to me in a diaper,
Oh,
and
yeah.
she said the excision didn't work because the minute I have to go, I either have to go or that's it, I'm giving up.
Oh, yeah. I had one
And
lady, she would urinate 10 times every night,
yeah,
and then she would like 40 times during the day, and then she would have her husband massage her from the inside through the vagina. And I'm like, you're basically pushing your hernia back in. That's basically
right.
what we're doing. But yeah, we fixed the hernia, all that went away. But severe, severe pelvic floor spasm.
Well,
Um,
I
hernia.
always fight with the urologists on this one that if you see the hernia on the film and they're describing this intense urgency, it's not like just frequency, it's like now.
Yeah.
That could we do something for the hernia before, say, you shove a interstim device in them?
Thank
Because
you.
if the hernia is easy relatively to fix and not to be then to have a
Yeah.
device in your body the rest of
Yeah.
your life.
Yeah. Thank you for that. But and hernias are so common. All of the other things are not common. Pudendal neuralgia is very, very, very uncommon.
Well,
Agree?
true pudendal neuralgia,
True
true, like
pudendal
true
neuralgia.
neuralgia. Can you
You can get, yeah, you can get pudendal nerve symptoms from pelvic
right.
floor spasm, but that doesn't mean you have to go getting pudendal nerve injections and blocks and surgery for it. You
Well,
fix
I
the
also
hernia,
think
that goes
people,
away.
gynecologists know what the pudendal nerve is. It's like they know what vulvodynia is, but you don't all have vulvodynia when you have a pelvic floor spasm. It's not,
Yeah.
just because your script says that does not mean that is what I think. And
So
I think like, especially in females, like people say, oh, if it's the clitoris, then it's the pudendal nerve. But what they're inputting everything in the area, it has to be like smack dab on the clitoris to be pudendal. The rest of it is ilioinguinal or genital femoral.
yes,
Really genital.
tell
Yeah.
me more about pudendal nerves, because I see a lot of over diagnosis of pudendal nerves. In fact, one of the questions, I should bring it up because it was kind of nicely worded. One of the questions was that, yeah, let's do this because this is important. The question is, how often do you find pudendal neuralgia diagnosed instead of a hernia? And then the patient is then taken down this rabbit hole, down the pudendal neuralgia pathway with blocks and ablations and so on. And this whole time it was pelvic floor spasm due to a hernia.
I see that. I see the patients nobody wants. So I see that
Well,
a
I
lot.
wouldn't say that. Patients, nobody can help.
No, well, but I see that, I see that in men almost all the time. I
Yeah,
don't know why a urologist or a primary care doesn't want to talk about other nerves. I see it all the time.
yeah,
I see it in women, and the doctor will write the script and put pudendal neuralgia on it, which then the person's brain has now grabbed onto that, and it like almost defines them. And
yeah.
so it takes months to explain what all the other nerves are. And the way I go around that is that's why I started with the grease pencil. And I had someone who I had been treating, a very difficult case, very young woman. who by an excellent doctor was told, have a hysterectomy for the adenomyosis. That's her choice, right? For adenomyosis. And then you should really do a device for the pudendal neuralgia. And
Yeah.
I had been treating her already for like 3 or 4 months. And I went back, and what she said was, the nerve pain is so sharp, I jump when I bend forward to get the remote control. Well, if you're bending forward, you're compressing, right? Think about where the nerve meets the leg. And then I started to evaluate, and sure enough, like I think within 3 weeks she had hernia surgery, and it definitely fixed that. Yeah, it did not fix the adenomyosis, but honestly, I think a nerve doctor hears burning and they think it's a nerve in the pelvis, must be pudendal.
Yeah.
Yeah.
Yeah. And people just don't wake up one day and get pudendal neuralgia. That's my argument. A lot of the nerve stuff is you can have nerve pain due to a hernia, but people don't just wake up one day and get an injury of their pudendal nerve. That doesn't happen. So to kind of take them through this very singular, you have pudendal nerve diagnosis is just a waste of time, and it can cause damage.
Well, and you could have pudendal neuralgia. Well, in men, I see like they recently retired. So like a lot of where I live, they're all on bicycles. Right. So like, or it'll be interesting. I'm going to develop a pickleball protocol, but that didn't come yet.
Oh, I love it.
But I think they never sat on a seat like that until they really, that's how their nerve got that's when I see a pudendal neuralgia.
Sure, the cycling for sure. If you're sitting on the couch, you're not going to get pudendal neuralgia.
Right. I see a lot of, and I have seen pudendal endometriosis. I'm not denying that there can be, and I've seen a ton of sciatic endometriosis.
Wow.
And I see that game more than like it, but is it ilioinguinal endometriosis, which I've only seen once in 15 years, where it was, the piece was literally removed and run through pathology. But I think there's a lot of mistakes on nerves. And you know what else I see? The gynecologist went in and they didn't see anything, so there can't be a hernia.
Yeah, that's an incomplete look. But actually this next question talks about that. I was told, this is a question. I was told that I had an inguinal hernia during my most recent endometriosis surgery. The endometriosis was removed from the hernia. Would it be common that the hernia may now go away?
Remove, so I
sounds like
sent you a very
endometriosis.
similar case.
Yeah.
But so I think that, first of all, the hernias that I see are not typically seen during endometriosis surgery because there are wads of preperitoneal fat laying against the nerve. And if that hernia is all the way through the retroperitoneum, you really need a decent specialist in there to fix it. So if you're taking the endometriosis out of the hernia, like if you've wrapped it inside the hernia and you do not have a superstar, not a general, I don't believe like every general surgeon can handle hernia. I mean,
they should be able to, but they can't.
Yeah. Well, I've taken family members to general surgeons who say, I don't do it this well. Go to my partner, sometimes they're becoming aware of that. But I think if you're doing a repair during an endometriosis surgery, and there's endometriosis in there, how are you repairing? Because you're not doing a mesh repair. Right. And if the hole was that big, do you need mesh? That's a good comment. People ask me that all the time about mesh. And it would be, I think, unsafe to be doing mesh while you're doing an endometriosis surgery until you know the pelvis is clear. So then how is it repaired? So yes, you could still have it. But the other thing is, once you have that compression on the nerve is all turned up and aggravated. So it may need something to quiet. It may need, I do some myofascial techniques to the nerve when you're healed. And you may need a little anti-inflammatory into the nerve and a little love.
Yeah, that's very true. Another question, can Dr. Sarrel discuss, you mentioned transversus abdominis and oblique reactivation. How do you reactivate the transversus abdominis and your obliques?
Well, I start with the breath, right?
Okay.
And understanding how to perform that contraction. And
Mhm.
then I go up from there. So first you're gonna do it in supine, your legs are not going to be moving. Then you're gonna be in supine, but you're gonna use, as you work your breath, you're gonna move your legs from adduction to abduction, from abduction to adduction.
Mhm.
I work in standing. I work in, what is your, and in terms of obliques, I try to do functional, like what is the person's function, right? Are they lifting groceries? Because then just putting a weight in the hand and going like, that's not how groceries move. Right. And I really have started to do dynamic strengthening of the obliques while you're moving, because that's when
Okay.
you really need them. So like maybe you're walking and I used to keep groceries in the practice, right? So then like people,
Hands, yeah,
yeah,
bottles of
and
water.
I like my diagonals, right? So I'm teaching breathing, right? So teaching, how to stabilize with the belly button in, and you're moving on a diagonal, which is a little bit of our PNF type working. And I have to say, like when somebody's been in pain a long time, your pelvic floor and your abs, because when you're in pain, you're like this.
Crunch up, yeah.
You
Mhm.
have to learn to lengthen. I put the towel on the floor and I teach people sort of like reverse downward facing sit-ups to control that
Oh, sure.
transversus muscle.
It's
And
really hard to learn the engagement specifically of the transversus abdominis, but it's so important because it's like your inner girdle. And if you look at imaging, most people have a poorly developed transversus abdominis muscle.
it's
It's
really hard to
thin.
describe it because I do it by touch,
Hmm.
right? And so when I'm teaching how to do it, I'm touching like that, but to describe it, I'm like, well, it's very hard to do. The new studio, I'll be able to demo.
Oh, really? Are you gonna have like a green screen or something? Okay,
The
demo.
green screen I would have to buy. So we're gonna hold off for a year or two before we put a bed up there, but I'll be able to have the lighting and everything. That'll be really nice.
Congratulations on that. That's really cool. Okay, another question. Do inguinal hernias hurt or become tender during ovulation? I noticed that my area hurts to the touch during ovulation. You were talking about that. It's hormonal, right? It's due to the estrogen peak that we get more pain of anything, including hernias during menses, I guess.
I feel like I should have brought my diagrams with me, but if you
Yeah.
think about, I usually stand up, but if you think about where the ovary sits and where the ilioinguinal and the genital branch of the genital femoral nerves are
Yeah.
so close together that it's very possible that with the hormonal fluctuations and with the inflammatory response of ovulation itself, that you're going to get more pain.
Yeah.
And I see that all the time. And I think that's how people end up at the gynecologist. Like if you're saying to me, my inner thigh burns during ovulation, unless you have some sort of strange adhesion wrapped around something or other, I definitely suspect hernia.
Yeah, for sure. Yeah, because that's ilioinguinal nerve. So the way I describe it is the ilioinguinal nerve runs in the groin. And if during normal anatomy, that nerve should be just hanging out where it normally hangs out, and it gives sensation to the inner thigh. However, if you add content there to compete with space with the nerve, whether it's fat or intestine, basically a hernia that's bulging or any of its contents, you're now competing for space in a very tight area, and any activity can kind of tickle that nerve and cause nerve-related symptoms. Burning, searing pain, hot poker is a common way to talk about it. And then also it's in the distribution of the nerve. So radiation of pain to the inner thigh is classic for most inguinal hernia type symptoms. And women, that canal is much narrower than in men. So you have less room even than men, and therefore less hernia and smaller hernia is necessary to spark that nerve pain.
Is that why I feel like no bulge hernia is much more common? And I mean, not that it's like that common in the first place, but
Yeah.
much more common in women.
Yeah. Yeah. And this whole idea of occult hernias or smaller hernias being symptomatic is because you don't see it be large enough yet, but it's large enough to tickle that nerve. So you get nerve pain, and people don't see their hernias. So they just focus on the nerve pain, not understanding it's from the hernia. And they take you down this whole nerve pathway, and people get nerves cut, nerves burned, nerve pain medication. And all they really need is a hernia repair.
Yeah, I think also they, I have stood at conferences and shown some of this on screen in a medical setting and had general surgeons stand up and say, but that's not a hernia. And so I know you do work with it.
I hate it.
The radiologist likes to see a big fat hole with something that's going to kill you going through it before they're going to call it.
Yes.
But that doesn't mean that's the only type of herniation that's going to cause pain.
Right. And most general surgeons do not understand that the size of the hernia does not correlate with symptoms. So large hernias may be completely no symptoms. Small hernias you can't even feel can have symptoms, and they deserve to be treated.
Yeah, we have a general surgeon, but then we also have a hernia specialist in the clinic that I work with. But the general surgeon will actually say, once it's a big hernia, okay, it could kill you, but it doesn't really hurt anymore.
Yeah, it doesn't hurt anymore.
You know,
wide open hole.
It's the guy that comes in and isn't complaining he's concerned about.
Yeah. Let's see, a couple more questions coming in. From a PT standpoint, is PT for the rectus abdominis different from general abdominal PT? And how are those different from PT for ventral hernias? If there's actually a protocol for ventral hernias. I have a question too, after you answer that, about visceral therapy.
I was going to say, I work very differently, and I do predominantly manual therapy, whether I'm doing visceral work or I'm doing myofascial work, or I'm helping you retrain your musculature. So when somebody says like abdominal wall therapy, I think of like a orthopedic setting where they treat and round and they hand you some exercises and walk away. Right. When you say rectus abdominis, am I doing rolling of the muscle? Am I, like, don't forget the rectus has, different segments to it. Am I seeing which segment fires? Am I working on your spine and the multifidus? Is there a rotator in the back of the spine that isn't firing just how we would like it? So that's what's going on with your rectus. And in terms of ventral hernias, I do some diastasis recti work. Is that the source of the ventral hernia? Sometimes I don't mess too much with that because those are the ones you can get really sick from. Yeah. If I really suspect one, I send them off. So like I was in a course once. It was supposed to be a course on like exercising with diastasis, and then like the woman was being evaluated and she domed, right? She like really domed.
Oh, passed out.
I'm watching her and I'm like, should I give her like my card so I could give her?
Because I call it like a pyramid. It comes out like a pyramid.
Right. And the instructor was like, no, she could learn to control that. And I was like, and under my breath, I'm like, before or after her small intestines are in her hand? Like, I don't, yeah. So I think that
what is visceral therapy?
Visceral therapy works with the organs. Supposedly it's developed by Jean-Pierre Barral. And it works with the fascia surrounding the organs that each organ has its own position and rhythm. And as woo-woo as that sound, it's extremely effective.
Yeah.
Because
I've had a lot of patients with that.
You're always going to have some sort of myofascial tension. And it really works well on that. The other thing I'll say in terms of ventral hernia and regular and inguinal hernia, femoral hernia, your pelvic floor is going to respond to all that, because the body works like a can. And if there's a weakness in one area, then the floor has to provide more of that support. So, sometimes to balance the abdominal muscles, you do have to lengthen the pelvic floor.
Got it. Does Dr. Sarrel believe in pain desensitization techniques? What is that?
I do believe that there is, that the body remembers pain, and that in many people beyond, we know that acute pain is up to 3 months, but after 3 months, there actually are cortical changes in the brain regarding pain. And so
Yes.
once the nerve has become sensitized, right, that pain is what we call central sensitization. So do I believe in desensitization techniques? Yes, but it depends on the person. So is pain neuroscience education going to work for you if you have a compression on the nerve? Probably not. But if you've had the hernia fixed and you know that there's not any endometriosis there, is it time to work on the central nervous system, to do your nice breathing, to understand? I've done dry brushing with patients so that they begin to feel a different sensation, right? To do all those things. Is that the time to do it? Probably. If it's not always like this, the example with central sensitization is the guy that was bit by the snake and almost died. And now if he hears a snapping branch, he has all those symptoms again. That's how right? So, but we had to treat the snake bite in the first place. So you have to it's not just about desensitization.
This viewer says, I need to use a cushion to sit because of tight pelvic floor muscles. I also get sharp pains in the right side of the groin 99% of the time, and centralized sharp pelvic pain. I was told I have pudendal neuralgia and I'm getting blocks soon, but I'm not sure how to rule out a hernia.
That's a good time to talk about diagnosis. Do you want to talk about ruling in or ruling out the hernia?
Yeah. Well, tell me a little bit about sitting being painful on a tight pelvic floor.
Well, I always ask like how, like when you say where is the sitting triggering it? So the pudendal nerve, if you're sitting against the sits bones and that's what's triggering it, then we think more about the pudendal nerve and we put you on a special pillow. But I saw a patient with this last week. Oh no, it's a sitting. When you sit, your abdomen comes over your groin.
Crush it and close your groin canal.
Right. And so you are, if you're getting groin pain, usually labia burning or wrap around back pain, when you're sitting, it's because you're compressing a whole different set of nerves. Yeah. And then like, to me, it's a lot easier to rule in or rule out the hernia than to start with
pudendal nerve.
blocks.
Yeah.
But
there's so few true specialists of pudendal nerve. So to kind of play around with it, I agree with you. I rule out a hernia. So sitting, bending, all of those close off the inguinal canal. So if you have a hernia in that region, it'll cause more symptoms. So prolonged sitting, bending, like to tie a shoelace, prolonged standing is another good one. Those are all kind of groin related pains.
I like to watch how they're sitting when I do
help.
the eval.
Say again.
I like to watch how they're sitting when we do the eval. You must do that too, right? They're sitting up on their
to the side.
I was going to say they sit up on their foot, so they're off to the side and opening the crease a little bit.
Yes. So if they're reclining backwards, and especially if one leg, that same leg, is put out instead of in, that's classically a hernia.
Yeah.
Or a hernia related complication from a menstrual repair.
Yeah, I think so. It'll be interesting. There's new research coming out by Maurice Chung about pain post endometriosis surgery. And in that, I've read it, but it's not published, so I can't. So not only does he do a bladder instillation, right? But he also, if they're continuing to have pain, he does ilioinguinal and genital branch blocks before he even touches the pudendal nerve. This is
Yeah,
the guy who his majority of his career was in pudendal nerve research, but he
yeah.
always does the ilioinguinal blocks first,
It's easier and it's less complicated and less complications, and it's more likely to give you the answer.
Yeah, I also I had a block, it didn't help. I don't think blocks are fail safe, do you?
They're not, but in some cases, because the nerve is not the issue, it's the hernia. If you block the nerve, then the hernia pain, it's like a radio, right? If you block the volume background noise of the nerve, then the volume or the noise of the hernia pain actually goes up. So if someone gets a nerve block and their pain actually gets worse, I think, oh, then there's definitely a hernia. It's not the nerve. Yeah.
Yeah. I also think it depends who does the blocks. So
Yes.
the same way it depends who reads your MRI.
100% true. Yeah, absolutely. Question about pelvic, like what else do people need to know about pelvic floor spasm? What symptoms do they usually come with?
Pain with sex, back pain, difficulty urination, constipation, sometimes diarrhea as well.
Mhm.
I always say it's pain with exiting of the stool rather than just like that belly pain, but
Yeah.
bloating. Because the pelvic floor serves to sling the whole system. And if the pelvic floor is too tight, you're gonna bulge out somewhere, not to misuse the word bulge in our conversation. And I also see quite a bit of hamstring pain and adductor pain from pelvic
Mm.
floor.
And do you recommend pelvic floor training, let's say after hernia repair?
It
Or-
depends on the person.
Yeah.
And I've seen different from the MDs, from the surgeons as well.
Yeah.
I think if it's somebody who was really not functioning that great and they had a lot of spasm to go into the surgery with, then they should definitely have the surgery after. Now, I work with someone who does a lot of obturator work, and it's not like an obturator hernia. It's like a thickened fat pad basically around the nerve.
Yeah.
And I think if you're going to have that done, before you run off in life, you should have like maybe 6 sessions of pelvic PT, because that totally changes your pelvic floor.
Yeah.
Yeah. And if you're going to go back to, I think, high-end athletics, then there should be some PT involved. But
Yeah.
then they send people home like, you don't need it, don't worry about it. See you.
Well, as hernia surgeons, we're always asked, what physical therapy do I need after surgery? And we don't really have a standardized protocol for physical therapy. There's a group out of Ohio State that is working on that. But it's not like evidence-based. It's like, oh, this would be a good idea to do.
Oh.
But does your society have any recommendations for post-operative physical therapy?
The society doesn't, but I put everybody on a walking program. For like so many reasons, right? And really the first 4 to 6 weeks, it's the first day you're home, you're walking like 5 minutes, even if it's in the house, out of every hour that you're awake, for like a lot of reasons, and then it progresses from there, so that by like week 2, you're really doing at least 30 minutes, like one, I think towards the end, I haven't looked at it in a while, but towards the end of the 14 days. And then I have people like doing abductor, like side walking, I think at about 3.5 weeks.
Oh, wow.
And yeah, I think that I've had a lot of anesthesia, and I think that it's important to move to get that out of your, to get the surgery behind you. Also to like not be you're not a broken, fragile bird anymore. You're a healing bird, and walking is a good time to like connect with that concept of healing and leave behind the concept of being sick.
Yeah, that's good. Be one with nature, walk outside.
Yeah. Right. But I've had people, I mean, one surgery, I was walking in malls, then I was like meeting patients to walk in malls for a long time, like in New York, people say everybody walks. I said, then start your timer so that you're getting the minutes in.
Yeah, that's really, really great. And then in terms of pelvic floor physical therapy appointments, my patients also get pelvic floor physical therapy without an internal examination. Is that mostly perineal examination only, or pelvic, not perineal, but just pelvic lower abdominal?
Yeah, if somebody, well, it depends on the case if you need internal work. I actually do a whole technique against depending where they are, if they've had mesh or no mesh or whatever, in the groin crease, right?
Okay.
And that's a manual technique to, like, I say floss the nerve, but it's probably not like actually flossing the nerve.
Yeah.
But I do some work there and some lower abdominal work. I also do a lot of rib cage work, because everything that goes on in your ribs and your diaphragm is going to have a reactive to your pelvic floor.
Yeah.
As well as in the mouth. So like your big clenchers definitely have pelvic floor spasms, and that's well proven, right? Because embryologically, the tissue in the mouth and the tissue in the pelvic floor develop at the same time, but there's all
So if
sorts
you're clenching your teeth, you're maybe clenching your pelvic floor?
Yeah, are your
Wow.
teeth grinders? Lots of pelvic floor problems usually.
Wow.
Yeah.
They should make it like a tooth, like how they have the teeth guards. They should get like a pelvic floor guard.
Yeah. Oh, I don't know about that, but there's a great pelvic floor PT in New York, and she was like the world's leading TMJ expert. And then she noticed this connection, and she like founded this, big deal. It was
That's
like a
so
big shift.
interesting.
Yeah. I always
That's
want her to come speak, but she's too busy for us.
How often do you treat men versus women?
Me personally,
Yeah.
well, I don't market that way. Most pelvic PTs will, especially if they're going to do sports and athletics, will treat men. I specialize in endometriosis. So, unless I'm treating somebody who's non-binary or who's trans, I'm not treating a lot of men, just because I focus on the endometriosis and the hernia. But once you put up all your hernia stuff, I get a lot of male calls.
Yeah, true. Here's a question. Is groin pain with prolonged sitting or standing more likely pain of the ilioinguinal nerve or the pudendal nerve? I would say hernia, but not nerve. I got 5 iliohypogastric blocks with my surgeon, and those did not help me. The 4th one caused my pelvic floor to be in a lot of pain afterwards. Therefore, I'm going to try pudendal blocks next with pain management. I don't understand why you're not just going to get evaluated for a hernia. Why does all pain have to be nerve pain?
Right. Well, let me tell you, I think they don't get evaluated for a hernia. That they don't get evaluated for a hernia because finding somebody who's really going to go through that MRI, there's like 4 or 5 people in the country.
I know.
And so then they end up in this pool of it's nerve, it's this, it's that, try this block, try that block. First of all, you're mentioning inguinal nerve pain, and you didn't mention any nerve that goes through the inguinal canal. The iliohypogastric nerve does not go through the canal, and the nerve doesn't either. And what I would do is I would get evaluated by somebody who knows what to do. I think you have the MRI protocol on your website.
I do.
And now you do consults also.
Yeah, for sure.
You do remote consults, and also map out those nerves. Don't let somebody inject something that isn't showing up in the right place.
And we just said, if you hit a nerve with a local anesthetic and your pain is worse, that's often almost always a hernia, because it's not a nerve problem. You're shutting down the nerve related pain, and so the hernia related pain becomes louder. And so don't go for the pudendal nerve. That the logic isn't to go from iliohypogastric nerve to pudendal nerve. Those are like 2 separate nerves. They cause different symptoms and different there's different reasons why you get those problems. They're just 2 different entities.
So go on my Instagram today. The picture is behind me of the nerve. Screenshot the reel, and take your fingers and enlarge it and trace where your pain is, or find any other picture. but ultimately find someone who's going to do a consult on the hernia, because if you rule it in or rule it out, a lot easier physically and financially to decide whether or not you're going to treat it than to just keep doing random nerve blocks.
Yeah.
Even though I do nerve blocks.
Yeah. Yeah,
Right.
which are not cheap. So I collaborated with you on that story, on that reel and on Instagram. So it's a great one. I collaborated because it was great. I loved it. And guess what? We're done. For our hour went by so quickly.
So quick. I can't, you have to come do a Instagram live with us. We'll set that up.
For sure. For sure. We'll do
So
that.
much fun.
That's it, everyone. That was fantastic. Thank you, Sallie. I'm so happy that we made this work. I've had so many questions to ask you and you answered them all for me, but I'm sorry for those who submitted questions and didn't get all those answered, but I think we did a good job getting as much of them answered this 1 hour as possible. And to all of you, thank you for joining me on Hernia Talk Live. We'll join me again next Tuesday on Hernia Talk Tuesdays. We'll have another great guest, and I hope you enjoy everything we do. That's all archived on my YouTube channel at HerniaTalk, and we will see you later. Thanks again, Sallie.
Take
Bye.
care.
Bye.
Bye.